HCC surgery. When to remove the tumor with surgery, and when to consider liver transplantation. When liver cancer grows in a diseased liver, surgery may offer the only chance for cure. This video explains who can benefit from hepatic resection versus liver transplantation, what outcomes you can expect, and how surgeons decide which operation is right for you through evidence-based content that has been professionally sourced by Saboor, consultant surgeon. Hepatocellular carcinoma, a primary liver cancer that typically develops in patients with chronic liver disease, presents a unique surgical challenge. The cancer itself must be removed, but the underlying diseased liver must also be considered. Two curative operations exist: hepatic resection, where the tumor is cut out while leaving some liver behind, and liver transplantation, where the entire diseased liver is replaced. Why this matters to you? The choice between these operations determines not just survival, but whether you face risks of liver failure from too little remaining liver after resection, or years on a waiting list potentially watching your tumor grow beyond transplant criteria. Understanding these trade-offs helps you partner with your surgical team. Before we dive deeper, let us establish what we are dealing with. Hepatic resection, removal of the tumor-containing portion of liver, is potentially curative when the cancer remains confined to the liver. The ideal candidate has a solitary tumor without invasion into blood vessels, preserved liver function as measured by the Child-Pugh classification, a scoring system evaluating liver disease severity based on laboratory tests and clinical signs, graded as A to C, and no evidence of portal hypertension, which is elevated blood pressure in the liver's main vein. These factors determine suitability for consideration of surgical removal of cancer. But here's where it gets interesting. These criteria are not absolute. Carefully selected patients with multiple tumors, or even major vascular invasion, can achieve long-term survival after resection at high-volume centers. The key factors surgeons evaluate are tumor location, the volume of liver that can safely be removed while leaving enough to sustain life, and liver function. Surgeons may combine liver ablation, destruction of liver tumor with heat by inserting a probe. For patients with cirrhosis, scarring of the liver, even Child-Pugh Class A patients, those with the best compensated disease, face mortality rates ranging from 1.9 to 4.5% within 90 days. Child-Pugh Class B patients, with more advanced dysfunction, face mortality of 1.7 to 22%. Surgeon. Preoperative evaluation focuses on two critical issues: confirming disease is liver confined using dynamic multiphase CT or MRI scanning, and determining whether the remaining liver remnant will be adequate. Advanced techniques like portal vein embolization can deliberately grow the portion of liver that will remain after surgery by blocking blood flow to the tumor side, forcing the healthy side to enlarge before the operation. 5-year survival after hepatic resection reaches up to 78% in carefully selected patients who have intact liver function, solitary lesions without vascular invasion, tumors 5 centimeters or smaller, roughly the size of a tennis ball, and negative surgical margins greater than 1 centimeter. That means for every 100 such patients, 78 are alive 5 years later. By contrast, patients with larger tumors, multiple lesions, or vascular invasion have significantly lower survival rates. In one series comparing tumor sizes, 4-year survival in non-cirrhotic patients reached 81% compared to only 35% in cirrhotic patients. This difference reflects not just the cancer, but liver-related mortality from the underlying disease. Most perioperative deaths after major hepatectomy result from postoperative liver failure, not bleeding. The degree of liver dysfunction, measured by Child-Pugh classification and presence of portal hypertension, is the most important predictor of post-resection liver failure and death. Intraoperative blood loss exceeding 1,500 milliliters and postoperative infections also independently worsen outcomes. The Milan criteria, established benchmarks that revolutionized transplantation for liver cancer, define who receives priority for a donor liver in the United States. These criteria specify either a solitary HCC 5 centimeters or smaller in diameter, or up to 3 separate lesions with none larger than 3 centimeters, no evidence of gross vascular invasion, and no spread to lymph nodes or distant organs. Patients meeting Milan criteria who undergo transplantation achieve 5-year survival rates comparable to those transplanted for non-cancer conditions. The 10-year survival for patients always within Milan criteria reaches 61.5%, with tumor recurrence rates of 13.3%. This means transplantation removes both the cancer and the diseased liver that spawned it. Here's something that might surprise you. Several expanded criteria now exist beyond Milan. The University of California San Francisco criteria allow larger or more numerous tumors. Australia and New Zealand have adopted these expanded criteria. However, in the United States, patients meeting expanded but not Milan criteria do not automatically receive prioritized access to donor organs. Downstaging, using treatments to shrink tumors that initially exceed transplant criteria, can bring patients within acceptable limits. The model for end-stage liver disease score, or MELD score, determines transplant priority based on how sick the liver is, not the cancer. Since 2016, the Organ Procurement and Transplantation Network adopted a downstaging protocol. Patients with tumors beyond Milan criteria may receive MELD exception points if they can be downstaged and maintained within Milan criteria with an alpha-fetoprotein level, a tumor marker, below 1,000 nanograms per milliliter. Eligible tumors before local regional therapy include one lesion greater than 5 but no larger than 8 centimeters, or 2 to 3 lesions with at least one exceeding 3 centimeters, each 5 centimeters or smaller, with total diameter of all lesions 8 centimeters or less. Patients successfully downstaged to within Milan criteria before transplantation achieve 10-year survival of 52.1%, with recurrence rates of 20.6%, better than patients whose disease was not successfully downstaged, who face 43.3% survival and 41.1% recurrence. Techniques include transarterial chemoembolization, injecting chemotherapy directly into the liver artery, feeding the tumor, radiofrequency ablation using heat to destroy cancer cells, and radioembolization using radioactive microspheres. Important caveat: patients requiring downstaging do not automatically receive exception points. Centers must apply to the National Liver Review Board, and approval is not guaranteed. The reported 90-day mortality rate in contemporary series for non-cirrhotic or Child-Pugh Class A patients ranges from 1.9 to 4.5%. For Child-Pugh Class B patients, it rises to 1.7 to 22%. Most deaths result from postoperative liver failure manifesting as progressive jaundice, accumulation of fluid in the abdomen called ascites, and eventual death typically occurring outside the hospital well beyond 30 days in patients with inadequate liver remnants. Fewer than 10% of deaths result from bleeding complications. Mortality can be reduced through appropriate patient selection, including preoperative volumetry, measuring the future liver remnant volume using CT scans, portal vein embolization, a technique where the portal vein on the tumor side is occluded to expand the future liver remnant when appropriate, and meticulous surgical technique minimizing blood loss and transfusion need. Two additional factors independently predict postoperative liver failure: intraoperative blood loss exceeding 1,500 milliliters, and postoperative infection of any type. Massive blood loss, defined as exceeding 800 milliliters, is also independently associated with early mortality. Postoperative infections decrease both overall and disease-free survival. If you have been diagnosed with hepatocellular carcinoma and are considering surgery, compile your medical records including all imaging studies, laboratory results showing liver function tests, and pathology reports if biopsy was performed. Request referral to a high-volume hepatobiliary center. Specialized hospitals performing many liver operations annually consistently achieve better outcomes than low-volume centers. Organize these documents chronologically and create a one-page summary listing dates of diagnosis, treatments received, and current medications. Ask these specific questions at your next appointment. Based on my tumor size and location, do I meet criteria for hepatic resection, or should I be evaluated for transplantation? What is my Child-Pugh classification and MELD score? If my tumor currently exceeds Milan criteria, am I a candidate for downstaging therapy? What is the 90-day mortality rate for my proposed operation at this center? And what is the 5-year survival rate for patients matching my tumor characteristics and liver function? Contact your surgical team immediately if you develop progressive yellowing of skin or eyes, new or worsening abdominal distension, confusion or altered mental status, fever exceeding 38.3 degrees Celsius or 101 degrees Fahrenheit, or vomiting blood. These may indicate liver decompensation, worsening liver failure, or surgical complications requiring urgent evaluation. If your tumor burden progresses beyond transplant criteria while awaiting surgery, request urgent reassessment for potential downstaging therapies. Surgery offers potential cure for hepatocellular carcinoma through two pathways: hepatic resection for those with adequate liver reserve and favorable tumors, achieving 5-year survival up to 78% in ideal candidates, or liver transplantation for those meeting Milan criteria, providing comparable long-term outcomes. The decision hinges on tumor characteristics, liver function measured by Child-Pugh classification, and center expertise. Perioperative mortality remains significant, particularly in cirrhotic patients. Downstaging strategies may expand transplant eligibility for selected patients initially beyond criteria. This information is for education. Always discuss your individual situation with your healthcare provider. The American Association for the Study of Liver Diseases provides updated clinical practice guidelines for HCC management at aasld.org, including detailed algorithms for treatment selection. The European Association for the Study of the Liver offers international consensus recommendations on liver transplantation criteria at eal.eu. Thank you for watching this video.